Okay, so now we're going to talk about cardiovascular disorders during pregnancy. Cardiovascular disorders during pregnancy can be problematic if you think about all the things we talked about last week with the fluid volume changes during pregnancy. If a woman already has an underlying heart problem, it can really cause issues. During pregnancy, we see that women already have increased intravascular volume. We already know that. They have cardiac output changes at birth, and so those things are greatly affected by a patient who already has an underlying problem. If a woman would have heart problems, by heart problems, I mean congestive heart failure or hypertrophy of her heart or something like that, then it can be problematic for her to be able to manage all the extra fluid that they get during pregnancy. There are volume changes that occur at childbirth and after that can play into this as well. For example, after birth, all that extra fluid, remember I said women get 1,500 mLs of extra fluid during pregnancy, plus they have fluid in the soft tissue. Most all women have some swelling in the soft tissue that's not even part of that 1,500 ml. So the cutting of the umbilical cord causes the process to reverse, and the exiting of the placenta from the body after birth, it makes everything starts to reverse. And so what happens is all this extra fluid that has been accumulated during pregnancy has to exit the body. What goes in must come out. So how does a woman get rid of all that extra fluid? Well, it all has to mobilize back into the vessels so it can go through her kidneys, and her kidneys can pee it out, essentially. So all the fluid in the soft tissue, all the fluid in the vessels, all moves, again, back towards the vascular space, and then the patient pees it out as her kidneys filter it. So for a person who has heart failure and has a weak heart, all that extra volume, sometimes they can't handle all that volume, and it will throw them into an exacerbation of heart failure. So that major period of adjustment, that first day or two after birth, can be crucial in causing heart problems. So we need to watch those patients very closely, because what happens is they get lots and lots more fluid in the vascular space. So they're hypervolemic for a short period of time as the kidneys are trying to metabolize and excrete fluid. But the heart has to, accommodate all that. So cardiac output is increased dramatically. Can the heart handle it? Trouble getting my slide to move. We know women who have cardiovascular disorders have increased incidence of miscarriage for probably two reasons. Number one, some of the medications that have been prescribed to them can be teratogenic in nature. If they got pregnant and they were on some of those meds, it may cause miscarriage. Also, anoxic issues. Remember I told you that uterus is not a vital organ. And so if a patient has a heart problem and they have an episode where they have anoxia or hypoxia, especially early in pregnancy, that can lead to a loss of the pregnancy. We had a patient once this is not an OB, but I was working on a trauma unit. We had a young 25-year-old gal who was like 8 weeks pregnant, was in a terrible car accident, and nearly lost her leg because the guardrail came up into the car, literally between her legs, almost amputated her leg at the groin. And she was 8 weeks, as I said, she was 8 weeks pregnant at the time. She was in ICU for several weeks. Then she came to the step-down unit where I worked. And when we got her, things were kind of okay initially with the pregnancy, and then all of a sudden, it seemed like once she got stabilized, then she had a miscarriage. So when we asked the doctor what caused it, he believed it was from anoxia at the time of the incident. She nearly bled to death at the time of the car accident. So he believes that blood was shunted away from the uterus and caused that pregnancy to be lost because of anoxia. So anoxic issues or episodes during early pregnancy can cause miscarriages. We know that women with cardiovascular disorders have more preterm labor, more intrauterine growth restriction. You're going to hear this term more and more, and you probably heard it in Chapter 9. IUGR, intrauterine growth restriction. This is when the fetus does not get enough nutrients and or oxygen, and so therefore doesn't grow well. And this is more like something that happens in the middle of the second through the third trimester, IUGR. If there's not enough oxygen is getting to the baby and or nutrients, it's going to affect the fetal growth. Incidence of congenital heart anomalies in children of mothers with congenital heart disease has increased. Interestingly enough, if a mom has congenital heart disease, her baby can be at risk of that also. Infective endocarditis. We're seeing more and more of this in the hospital, and this is usually related to abusing injectable drugs. So if a patient gets pregnant and is abusing IV drugs, we need to assess them for infective endocarditis. They'll need IV antibiotics to treat that. Marfan syndrome is a genetic anomaly that is a connective tissue disease. But that connective tissue disease causes problems with the aorta itself and usually causes ballooning and aneurysms. And so those patients may have to have surgery to repair those aneurysms. What if a patient's had a myocardial infarction, also known as a heart attack? Usually associated with very poor outcomes. I've seen 2 patients who had heart attacks. They both died. And both of them had the heart attack right after they had the baby, right after the birth of the baby. And it was because of all the extra fluid, the increase in cardiac output and the increase in fluid that the body had to move through the vessels was just too much and caused the patients to have a heart attack. Management for our patients, cardiac pregnant patients. We want to minimize stress on the heart as much as possible. We want to watch for signs of what we call cardiac decompensation, which is the inability of the body to maintain cardiac output. Usually, cardiac decompensation equals an exacerbation of CHF. That is usually what that means. Cardiac decompensation equals an exacerbation of congestive heart failure, meaning the heart can't beat well enough to move all the blood through the heart that it needs to. What are signs of cardiac decompensation? Dyspnea, moist cough, palpitations, irregular weak pulse greater than 100, generalized edema, crackles in the lung bases, tachypnea, cyanosis at nail beds. What does all that indicate? CHF. Those are all signs of CHF. So with these patients, we want to limit the demands on the heart. That means limit activity. If a patient, is exercising and running or exercising in other ways, that certainly increases the demand on the heart. So we want to avoid that. So limit activity. And then, of course, remember the risks immediately postpartum when all that fluid in the soft tissue mobilizes back to the intravascular space. And again, if this is confusing to you guys, or it didn't make sense, please write a note and remind me on Monday, and I will go over it with you again. There's a drug that we use in pregnancy called terbutaline, or brethine is I believe the brand name. And we use it in pregnancy for preterm labor, but we cannot use it. We cannot use it for patients who have signs of cardiac decompensation, or that we're worried about that, because what happens is the symptoms look like the side effects of the drug, terbutaline, looks like cardiac decompensation. So they could just be having a side effect of the drug, tachycardia in particular, and we don't know if it's side effect of the drug or if it's cardiac decompensation. So we want to make sure we avoid terbutaline/brethine in our patients with heart problems, heart disease. Cardiac medications as needed. How do we know what, there's a lot of cardiac meds heart patients get. Which ones are safe, which ones are not safe? Well, we have to go through those one by one and decide if this is something that's safe in pregnancy or if it's not. If a patient has done their due diligence and went to the doctor before they got pregnant, then you can discuss with the doctor. These are safe, you may stay on these, but these you need to come off of, and we'll substitute them with this. So in a perfect world, that's what would happen. In a non-perfect world where the patient's already pregnant, then we need to review their drugs and change them accordingly, at least through the first trimester while organogenesis is going on. Once the organs are all formed, then we may be able to put them back on some medications. There may be some medications that we pulled off of them because we worry about organ formation of the fetus, but after they're 15 weeks along, we can put them back on that. So that's an option as well. Okay, that's the end of the cardiac material. Most of the rest of these are going to go fairly fast. Skin disorders. Melasma and chloasma we already talked about, and that is a brown pigment over the face um, from progesterone, not from estrogen, but from progesterone. And if it's melasma, it's pregnancy related. If the patient's not pregnant, then we call it chloasma. Just that simple. Vascular spiders are areas of redness on the skin that are from increased estrogen levels in the blood. Palmar erythema, and I've got a picture of that on the next slide, is red palms. Again, increased estrogen levels in the blood during pregnancy. And then back to the striae gravidarum or stretch marks again, things that we see during pregnancy. So here's a picture of a patient with some really bad stretch marks there on the right. And then on the left, palmar erythema from increased estrogen in the blood. Neurologic disorders. There are a lot of neurologic disorders a patient may have. One of the most common ones is epilepsy or a seizure disorder. If a patient has a seizure disorder, one of the biggest problems that we have is patients don't want to take their meds. They're always afraid that their medications are going to cause problems with the fetus, and it could. So a lot of times they are not compliant with their medication because of that. So we want to look at their medication list and change it if necessary. Dilantin and some other, Dilantin is one good example of a teratogenic drug, but there are others. For the patients with seizures, we usually try to put them on Keppra and Lamictal during pregnancy. Those are safe. We avoid Dilantin, we avoid Depakote, we avoid Valium as examples of things that we know are teratogenic. And a lot of drugs we don't know. Obviously, it would be unethical to give somebody a drug just to see what happened. So we don't get the opportunity to find out about a lot of drugs except just from incidences. So, we don't experiment with these drugs on pregnant women to see what happens. We just, if they happen to take them, then we get information. And that's really the only way we get our information about drugs that are dangerous in pregnancy. Bell's palsy, I've got a picture here on this slide of Bell's palsy, and it's usually a mouth that's kind of drawn to the side, and the eye you see has a sort of a different look to it, and that is, we look at that and what do we think? We think of stroke. Bell's palsy is not a stroke. It can occur during pregnancy. Cause is not well known. We do see it sometimes with preeclampsia, but it is, and hypertension. It's not necessarily caused by that, but there's an association. If a patient develops Bell's palsy during pregnancy, it usually will be self-resolving after pregnancy. Autoimmune disorders. So as you may know, an autoimmune disorder occurs when the body's immune system goes into overdrive. It's trying to fight something, and it starts fighting your own tissue and damaging your own tissue by an overactive immune system. Autoimmune diseases are diseases like lupus, ulcerative colitis, Crohn's disease, just to name a few. There are others. Alopecia is often considered to be an autoimmune disease. There are many others. Those are just some examples. Patients with autoimmune disorders, we do not recommend their immunosuppressive medication during pregnancy because we don't want a baby that's born with a poor immune system. So we often will take them off their immunosuppressive drugs. If a patient has an autoimmune disorder, one of the biggest drugs of choice is immunosuppressive agents, which suppress their immune system and stop it from being in so much overdrive. So in pregnancy, we'll try to take them off of those drugs. It usually works out okay, though, because oftentimes what we see is autoimmune disorders will improve during pregnancy, and here's why. Pregnancy itself tends to tamp down the immune system a little bit, sort of make it kind of not be as effective. So if your immune system is kind of tamped down and is kind of slowed down, then the effect it has on your body for that autoimmune effect starts to go away. So if autoimmune disease is an immune system in overdrive and pregnancy relaxes the immune system, then it makes the disease process better because the body is now not attacking itself because the immune system is no longer in overdrive. So most of the time when people have autoimmune disorders, they'll say during pregnancy, I haven't felt this great in years. I feel wonderful. I'm not even on my meds and I feel great. And so usually they do quite well during pregnancy. Problem is, 6 weeks to 8 weeks after pregnancy, they will see that their disease returns. Now, it doesn't necessarily come back and have a bad exacerbation, or it doesn't get worse necessarily, but it will come back at about the same level that it was pre-pregnancy. So they may, a lot of times they'll think, I'm cured, and then they'll find out sadly that within 2 months after the baby's born, their disease has recurred at about the level that it was before. But they do see an improvement in their symptoms during pregnancy with autoimmune disorders. HIV and AIDS. So a patient who already is infected with the HIV virus or has AIDS, and I know again you all have not had that yet in this semester. You'll cover AIDS in much more in depth. As you may know, HIV is the virus that causes AIDS, and you can have the HIV virus in your body and not have AIDS. AIDS is when you have, you're far enough along that you have the disease process. Whereas if you're HIV positive, you may be asymptomatic, just have the virus, not have symptoms. So preconception counseling is very important for a patient who's HIV positive or who has AIDS. Oftentimes, unfortunately, patients will become pregnant and not even know that they're HIV positive. So that's a possible problem. We know that HIV suppresses the immune system. So patients with HIV or AIDS develop opportunistic infections. Those are infections that most people don't get. Most of the time, our immune system protects us from weird, wacky viruses and infections that you just don't see. But with HIV, you see these weird, wacky viruses that nobody ever gets, except like birds. There's several viruses that only birds get. But if you're HIV positive, you can get those weird pneumonias and things that healthy people just don't get. HIV positive people do get it because of their suppressed immune system. So we want to treat any opportunistic infections as they develop. Pregnancy does not accelerate HIV or AIDS, does not make it worse. Women who are HIV positive or who have AIDS should receive the same therapy that non-pregnant people get, which is HAART, highly active antiretroviral therapy. This antiretroviral therapy has been shown to be very effective. We used to think of AIDS as a death sentence, and now it is very controllable and manageable with this antiretroviral therapy. Very manageable. There's a lot of symptoms that accompany that therapy, though. So we worry about a little bit about the baby and exposure to this antiretroviral therapy. So a lot of times what they'll do is they'll take the mom off of it during the first trimester, during the weeks that the organs are forming, also known as organogenesis. And once the organs have all formed, after the first trimester, they'll put them back on their antiretroviral drugs and leave them on it for the rest of pregnancy. We do not want them to have an AIDS exacerbation during pregnancy. So that will be important. If the mom takes antiretroviral therapy as prescribed, we believe that it's only about a 2% chance that mom is going to give the baby HIV. So the babies can be born disease-free. In the United States, of the women who take antiretroviral drugs, only about 200 or less are infected every year. Also, we want to test this patient for other STIs and hepatitis, because if they have been exposed to HIV, which is sexually transmitted or bloodborne, then they've probably been exposed to STIs and hepatitis, and because their immune system is probably not functioning at top level, if they were exposed, they're very likely to be positive for other STIs and hepatitis. So we definitely need to test them for that. Antenatal, which means during pregnancy, and intrapartum. And intrapartum means during labor and delivery. Management of HIV in pregnancy, during pregnancy and during the labor and delivery period. Depending on the viral load of the mom, we give a drug to the mom and baby, and I can never pronounce this, zidovudine, IV zidovudine. We will give it to mom during labor. We will give it to the baby for up to 6 weeks post-birth for prophylaxis to prevent transmission of mom to baby. Also, we typically do C-sections. There's some question about if mom's HIV positive and her viral load's low, can she have a vaginal delivery and all that. What I've seen in practice is if you're HIV positive, you get a C-section, period. And that's mostly what's practiced. In addition, That baby is bathed very quickly after birth. So this is a baby, we do a C-section, we get that baby wiped off because there's a lot of blood that gets on a baby during a C-section. Wipe them off very quickly, and this baby is bathed quickly to prevent any opening in the skin for blood to get in. Also, anything that would cause the baby to get a nick in the skin before birth would be avoided. For example, we can put a little scalp electrode on the baby's scalp, and it's a little needle, not needle, but a little probe that goes into the baby's scalp to help pick up the baby's heartbeat, but it's an opening in the skin. So if your mom's HIV positive, you would never want to do that. So anything that causes an opening in the baby's skin should be avoided, of course, to decrease transmission. Immediately after birth, as I said, every effort should be made to wipe the baby free of all bodily fluids. Bath will be done very quickly. All staff obviously will observe universal precautions, which we should be doing in every patient, because we may have a mom come in who have a baby who's HIV positive and we don't even know it. So we should try to treat every patient like they could be HIV positive, because they certainly could be. As I said, C-section is preferred over vaginal birth, even though some doctors say they can look at the viral load and maybe have a vaginal delivery. I will tell you that for the most part, I've seen C-section be preferred. Also, no breastfeeding, certainly, because HIV is found in breast milk. Last part of this chapter is substance abuse. And substance abuse is certainly a problem. And we see it, a lot of the substance use in this country is with younger women or who have babies. So we're seeing it a lot. I want to mention that also a drug substance is going to be smoking. Of all the drugs that a mom can take, smoking is one of the absolute worst. And we really encourage moms to, if you can't quit, cut down. If you smoke 8 cigarettes a day, can you cut down to 5? If you smoke 5, can you cut down to 2? Can you smoke every other day? Anything they can do to cut down, it's going to be helpful. Smoking is a vasoconstrictor. So therefore, we're going to vasoconstrict those vessels in the placenta and minimize the oxygen and nutrients that baby gets. Things that we see with smoking in pregnancy: bleeding complications, miscarriage, stillbirth, prematurity, placenta previa, placenta abruption, low birth weight, sudden infant death syndrome. And you'll learn a little bit later why when we start talking about those conditions, but all things we can see because, again, smoking is a vasoconstrictor. Cocaine or other stimulants, any stimulant drug that you take is a vasoconstrictor, and therefore it raises blood pressure, and it can do damage due to the raised blood pressure. So any stimulant, cocaine, methamphetamine, even to a smaller degree, your Adderall and Ritalin and things like that, to a much smaller degree. But all stimulants are vasoconstrictors, which raise the blood pressure. And raising the blood pressure can damage the placenta. The placenta is nothing but a bunch of blood vessels. If you think about what happens to your blood vessels from smoking, it raises your blood pressure. Raising your blood pressure damages your blood vessels over time. If we damage your blood vessels by smoking, you can damage the placental blood vessels by smoking as well. Women who are addicted to drugs during pregnancy are very unlikely or unwilling often to report what they usually use drug-wise because they're worried about losing their children. And there is a law now in West Virginia that if you have a positive drug test for any substance that you're not prescribed, that gets you automatically a CPS visit. That doesn't mean you're going to lose custody of your baby. There are so many women in West Virginia who are using substances, we couldn't possibly take all their babies away. We could not do it. So we have to look at the worst of the worst situations, and if a mom's on a treatment plan and she's following the treatment plan, she's probably going to get to take her baby home with her. There are also very little available in terms of rehabilitation for pregnant women. Very little rehab available, and what few there are long waiting lists. So as I said, women who abuse substances in West Virginia will get a CPS visit, but again, if they give them the opportunity to go on a treatment plan, If they're following the treatment plan, they're probably going to get to keep their baby. We have a lot of patients now who don't get prenatal care. The reason they don't come in for prenatal care is that they're worried about losing custody of their baby. They know they'll have a drug test. So they just drop in during labor. They haven't been to the doctor since they found that they were pregnant, but drop in for labor and delivery, have the baby, and then, if we drug test them, and I think they drug test everybody now when they're admitted to labor and delivery, then CPS will visit them, but if they can come up with a plan, then oftentimes they don't lose their children. Now, if it's multiple children and there's been multiple incidences and they've lost other children, then they're faster to take those children. But a lot of moms who are substance abusers do not lose custody of their children. Or it goes to their mom. The baby goes to her mother or her sister. And so essentially, if your baby goes to your mother or sister, they're basically going to give you your baby back. So that's a problem as well. Already talked about a lot of this about underreporting. We need to be very non-judgmental and matter of fact when we talk to these patients because they're going to underreport their use. So we need to not act shocked if they say, I take 20 Percocet a day or whatever. We need to not act like our heads are about to blow off because we want to get the illicit truth if we can. So be very cautious and non-judgmental if you want to get your patient to communicate with you. In the past, our biggest drug problem has been opiates, but that has branched out now to a lot of other drugs. Opiates are now harder to get. Even heroin become hard to get. Fentanyl is the big problem that we see now, which is just, a synthetic opiate. But we're also seeing a lot of methamphetamine, a lot of marijuana laced with methamphetamine. We're seeing some other drugs, and I can't remember some of the names, but that are like elephant tranquilizers and all this weird stuff, ketamine. So it's like they're just looking for something else to abuse. But it really did start out with opiates, spread to marijuana, methamphetamine, and has now spread to other categories. So you might find anything in mom's system. We're seeing a lot of abuse of Neurontin. I mean, there's other drugs too that you wouldn't think would be abusable, but they're in large doses they are. Okay, that's the end of this chapter. Please let me know Monday if you have questions, and we'll review any questions that you may have.